Следующий доклад доктор Зайдман, Соединенные Штаты, имплантация миниатюрного телескопа вместо ИОЛ при факоэмульсификации катаракты у пациентов с ВМД. Ну вот у нас они не сертифицированы, эти телескопы, к сожалению. Ну, посмотрим.
А то бы мы их, конечно, ставили и ставили, да?
Да, конечно.
Thank you. I am going to do a brief slide presentation, and I'll show you a video on using the telescopic lens implant in patients with cataract and dry macular degeneration. This device has been available in the United States since 2012. I understand it's also available in the EU and other parts of the world. It works as a telescope. It provides magnification beyond the scar, let us say, that you'll see in macular degeneration. As you can see it on this person's finger, it's 13.5 millimeters in diameter, 4.4 millimeters in depth, and it comes in 1 magnification power. It's based on telescopic technology using wide-angle micro-optics, and it sits in the capsular bag after lens extraction. And it primarily works by providing a magnified field, a 20-degree field, that's projected an image onto 55 degrees of the retina, so it goes beyond the area of the macular scar and enables people to combine their sensorial apparatus and their visual apparatus to interpret the objects they're looking at. In the United States, at least, you can use it only on dry macular degeneration. Patients cannot have had any intravitreal injections within 6 months after surgery. The person has to have at least a moderate cataract. And in the United States, again, patients have to be older than the age of 65. They have to have vision that is measurable, somewhere between 2160 and 2800. They have to have an anterior chamber depth that's adequate to support the lens implant. They cannot have any significant gutata. They must have a cell count that's over 2,000 if they're 65 and over 1,800 if they're more than 85. They can have glaucoma, but it has to be controlled. Now, these are some slides from the manufacturer indicating, at least in the United States, how the prevalence of macular degeneration will more than double between 2010 and 2050, from approximately 500,000 patients to 1.3 million patients, and therefore there will be an increased need for optical devices to help these patients see. If you're going to use this, you have to understand that this requires a team of eye care providers, not only the retinal specialist and not only the anterior segment surgeon, but it's very important to have a low vision team of opticians, optometrists, to help manage the patient and their expectations. One of the difficulties with using this is for patients to understand how this device will work in their eyes. They have to be motivated to go through several months of rehabilitation after the device is implanted. Before the device is used, the patients are screened by the low vision team by using an external telescope which is placed on the patient's dominant eye, and we test the patients to make sure that if they have a telescope in one eye, they will still have adequate peripheral vision, so they're able to use their 2 eyes together. We also have to make sure that the telescope will give some visual improvement. If the macular scar is too large, then the patient gets no visual improvement with the external telescope, they probably are not a good candidate for the procedure. Finally, you have to explain to the patients that this is a process of rehabilitation. It's similar to if they've had orthopedic or hip surgery, and they'll have to spend some time after the surgery with the low vision team learning how to use this device. We define a successful patient as someone who has a visual acuity improvement of several lines of vision, but most importantly, they can use the magnification to enable them to recognize the faces of family members or other objects, and they're able to view a television screen. And we teach them, as I said, to use the telescope for central vision and their fellow eye, which could be pseudophakic or phakic, for peripheral vision. The procedure is essentially a 2-stage surgical procedure. You soften the globe however you'd like to do that, with a balloon or with mannitol. And then basically you start with a classic phacoemulsification with a large capsulorhexis, and then stage 2 you essentially convert to something equivalent to an extra cap. You enlarge your corneal scleral incision to 12 millimeters, put the IMT into the eye, suture in the incision. You have to do a peripheral iridectomy, and then in case for some reason you can't put the IMT into the eye, you have to have a standard lens implant available. This is just a little cartoon from the manufacturer that demonstrates the steps of the incision, starting with the capsulorhexis and the limbal incision, implanting the lens, and then having the lens implanted in the eye. This is an external view of the size of the telescope in comparison to the eye. Here's another cartoon demonstrating the telescope going into the eye. And here's the video, if we could start that, if that will. So you can see in this video the incision has been increased or enlarged to approximately 12 millimeters. The capsule bag has been filled with viscoelastic, the anterior chamber has been filled with viscoelastic, and I'm inserting the telescopic lens into this patient's eye. The first step, of course, is to get the inferior haptics. The manufacturer will provide some special insertion forceps for you to use during the implantation of the telescopic lens implant. The inferior haptic has been placed into the capsular bag, and now you can see at the bottom of the screen a little bit of the superior haptic, and that I will shortly place into the bag using a two-handed technique. Typically I'll use forceps in one hand and a hook in the other hand to rotate the superior haptic into the bag. Okay, next. These are some post-operative photos showing how it looks in some of the patients. The photo on the left is a recent post-op. Sutures can be managed the way you would have managed sutures in an extracapsular incision for astigmatism control. The first 200 patients were reported in the American Ophthalmology Journal. 60% of them had a visual improvement of more than 3 lines of vision, and 93% of them had vision either equal or greater than their starting vision. There is a moderate to small amount of endothelial cell loss, but none of the patients had any corneal decompensation or retinal complications. To date, over 400 patients, well, as of 2015, over 400 patients have had this implanted. 5% of the patients had the surgery aborted in the operating room because the IMT could not be implanted. And visual acuity improved from 2300 to approximately 2150 on average, and 60% of the patients gained more than 3 lines of vision. As I said, the only problem we have really is there is a moderate to large amount of endothelial cell loss, approximately 20% at the time of surgery, 3% per year, but it can, the largest to date has been about a 35% cell loss in most of the patients, but only 5 patients ever required a corneal transplant. Other patients can develop pigment deposits in synechiae, and 4% of the patients had the lens implant explanted because they were unhappy with their ability to ambulate and function. So to summarize, this is a useful device for a highly motivated patient who understands how the telescopic lens implant will improve their central vision in one eye, and who will understand how to be able to use the 2 eyes together. Thank you. Any questions?
Thank you. Доктор Зайдман. Пожалуйста, вопросы.
One question for me. Looks a very big lens in the bag.
Yes.
And how stable it is during the years, this kind of lens, and tell us something about the cost of this lens.
The second's a good question. The lens is very stable. For those of us old enough to remember the days of old extra caps, the lens stays in the eye the same way a 3-piece lens implant that was used during the era of extra caps will be. There's no instability. If you get it into the bag, then it remains perfectly stable. I've never tried putting it into the sulcus, and the manufacturer does not suggest that you put it in the sulcus. I understand some people have done that. I can't comment on the results. But if you get the lens in the bag, it's perfectly stable. The lens is quite expensive in the United States and in the EU. Government health insurance covers the cost of the lens. I can't speak for other countries, but it is an expensive device. I understand that the company charges about $15,000 for the cost of the lens, but as I said, health insurance plans in most of the world do cover the cost of it.
Yeah, in Italy is even much more, that's why.
Say that again?
In Italy, it's even much more the price. So it will not spread until they will make lower the price.
Yeah. Thank you.
Thank you.